So, today we're diving into one of the most time-critical events in all of medicine, an intracerebral hemorrhage, or ICH. This isn't just another type of stroke, it's a full-blown neurological catastrophe, and it demands immediate, precise action. Let's break down exactly what's happening in this emergency.
You know when a patient tells you they're having the worst headache of my life? That phrase should set off alarm bells for any clinician. Now, not every patient says it, but it's the classic signpost for a potential brain bleed, a life-threatening event that's already underway. So, what exactly is an ICH? Well, unlike an ischemic stroke, which is caused by a clot, an ICH is what we call a hemorrhagic stroke. A blood vessel inside the brain tissue itself, the parenchyma, has burst. This isn't just a leak. The blood is toxic to brain cells, and as we're about to see, it creates a terrifying pressure cooker situation. And this is what it looks like. On a non-contrast CT scan, blood shows up as bright white, or what we call hyperdense. That really stark white area you're seeing, that's the hematoma. That's a collection of blood that should not be there, and it's actively compressing and damaging the brain around it. This image is the smoking gun. It's the definitive proof.
Okay, to really get why this is so dangerous, you have to think about basic physics. Your skull is a hard, rigid box. It doesn't expand. Inside, your brain, blood, and spinal fluid are all in this perfect pressure balance. When you suddenly introduce a bleed, it's literally like trying to inflate a balloon inside that sealed box. The pressure has nowhere to go, so it starts to crush vital brain structures. This is what can lead to brain damage and, very quickly, death. And because of that rapidly rising pressure, everything that happens from this point on is a race against the clock. The entire goal is to get from the very first symptom to a definitive scan as fast as humanly possible. So these are the signs we're looking for. Things like weakness on one side, what we call focal deficits, really depend on where in the brain the bleed is happening. But it's that whole constellation of symptoms, especially a decreasing level of consciousness, that screams that something is terribly wrong. And here's the really scary part. About half of these patients will actually get worse after they arrive at the hospital because the bleed is still expanding. This comparison right here is absolutely critical. It explains why we race to that CT scanner. The treatments for the two main kinds of stroke are polar opposites. For a bleed, you have to stop the bleeding. For a clot, you have to bust the clot. Giving a clot buster drug to a patient with an active brain bleed would be, it would be an absolute catastrophe. You cannot tell the difference based on symptoms alone. You have to see the picture. So in the emergency room, it all comes down to this trio of immediate actions. Number 1, get the CT scan. That is non-negotiable. Number 2, get a baseline assessment of how severe the stroke is using a standardized scale. And number 3, do a quick finger stick to check their blood sugar because, believe it or not, very low glucose can sometimes look exactly like a stroke. Okay, the CT confirms it. It's a bleed. Now the clock doesn't stop, it just resets. A new race begins, the race to stabilize the patient and stop that hematoma from getting any bigger. So let's just frame our thinking here. We have a confirmed active bleed inside the skull. What are the two absolute top priorities? The two fires we have to put out immediately to save that patient's brain.
Priority number 1, blood pressure. It's often high blood pressure that caused the vessel to burst in the first place. And if it stays high, it's just going to keep pumping more blood into that bleed, making it bigger. So we have to bring it down, aiming for a systolic pressure around 140. But you have to be careful. If you drop it too low or too fast, you risk starving the rest of the brain of blood. It is a very delicate balancing act.
And priority number 2, we have to slam the brakes on anything that's preventing the blood from clotting. If a patient is on a blood thinner like warfarin, we have to reverse it right now with things like vitamin K and PCC. For heparin, we use protamine. Now, what's really interesting is that for super common drugs like aspirin, studies have shown that just giving a platelet transfusion doesn't really help and might even be harmful. So the standard of care is simply to stop the drug. All right, so with blood pressure coming down and any anticoagulation being reversed, the patient's journey now moves to a very specialized place, the neuroscience intensive care unit. This is where the marathon of management really gets underway. Life in the neuro ICU is all about meticulous, obsessive attention to detail. The goal is to prevent any secondary brain injury. That means constant neurochecks, making sure their airway is protected, using compression devices on their legs to prevent blood clots while they're immobile, and aggressively treating any fevers or high blood sugars because both of those can make a brain injury worse. Now, here's a really important clinical pearl. An injured brain can be very irritable, which makes it prone to seizures. And seizures can cause even more damage. So if a patient has an actual clinical seizure, we treat it right away with medication. But, and this is the key takeaway here, the guidelines are very clear that we should not give these meds just in case or prophylactically. We treat the event, we don't pre-treat the risk.
So when do the surgeons get involved? Well, for many patients, the management is all medical. But surgery can play an absolutely life-saving role. The clearest reason to operate is for a bleed in the cerebellum, which sits at the back of the brain. That space is very tight, and a bleed there can quickly compress the brainstem, which controls breathing and consciousness. In those cases, or for any patient who is rapidly getting worse, having a neurosurgeon go in and remove that clot can be their only chance.
Okay, so we've been deep in the weeds of the acute crisis. Let's zoom out now and talk about the bigger picture. Why did this happen, and what does the future look like for survivors? When we look at the causes, the vast majority, we're talking about 80%, are what we call spontaneous or primary. This just means they're caused by long-term damage to the small blood vessels in the brain. That other 20% is secondary to some other underlying problem, like a brain tumor that starts to bleed or a ruptured aneurysm. We're going to focus on that big 80% slice of the pie. Now, within that 80%, it really boils down to two main culprits, and the location of the bleed on the CT scan is our biggest clue. The first is hypertensive vasculopathy. This is just damage from years and years of high blood pressure, and it tends to cause deep bleeds in areas like the basal ganglia. The second is cerebral amyloid angiopathy. This is where amyloid protein weakens the vessel walls. This condition causes bleeds that are closer to the surface of the brain, what we call lobar hemorrhages. And it's usually seen in older adults. And we can't understate how serious this condition is. The prognosis is incredibly sobering. The reported mortality for intracerebral hemorrhage at 1 year is around 50%. It is and remains the deadliest type of stroke. To help clinicians get a handle on that risk and to guide those really difficult conversations with families, we use tools like the ICH score. It's a pretty simple scale that assigns points for different factors we see right when the patient comes in. It looks at their level of consciousness, the size of the bleed, their age, and whether the bleed is in a particularly dangerous spot near the brainstem. By adding up the points, the score gives us a more objective prediction of a patient's chance of survival at 30 days. Okay, so let's do a quick recap. What are the absolute must-know points? 1. ICH is a bleed inside the brain tissue, and it's a massive emergency. 2. Imaging is everything. A non-contrast head CT is the first and most critical step. 3. The two immediate priorities are to control the blood pressure and reverse any blood thinners. 4. The two main causes are hypertension, which causes deep bleeds, and amyloid angiopathy, which causes lobar bleeds. And finally, the prognosis is very serious, but we have tools like the ICH score to help us estimate it. And that brings us to our final thought. We've spent all this time talking about the complex, high-tech, in-hospital management of a disaster that's already happened. But since chronic, uncontrolled high blood pressure is the #1 driver of these bleeds, the most powerful tool we have happens long before a patient ever gets to an emergency room. It really leaves us with the critical question: how can we, as a society, do a better job of preventing this in the first place?